Thank you. Yeah, thank you. So thank you so much again for inviting me to this talk. So I'm going to talk about liver transplantation in children, the hepatologist perspective. So I would like to talk about whether what's happened with the liver transplantation over the last 3-4 decades, and is the liver transplantation the right choice for children with liver disease, and the worldwide experience and long-term outcomes, and then move on to the next set of discussion topics. So if you take you through the history of liver transplantation, I marked the most important points. So the first human liver transplantation was attempted in 1963. It was very unsuccessful, so they paused it for a time being. And in 1967, Thomas Starzl from US performed the first transplant where there was a survival for a period of time. I think the next major change was when immunosuppressive regimens were invented and the new immunosuppressive drugs were there, because rejection was a major problem. And in 1979, cyclosporin was introduced. And I would like you to remember this year, 1984, when there were less than 20 active liver transplantation centers in the world. So that is like 30 years from now, back from now. And in 1994, the tacrolimus was approved. So that is the basis of the immunosuppressive regimens all over the world now. So that is really, really important. And in 2013, at the time of the publication, there were liver transplantation centers in more than 80 countries across the world. So if you look across Europe, you can see that most or every one of the countries have a transplantation program. And if you look at Great Britain in particular, up to 2009, there were 13,000 transplants performed. And as compared to Southeast Asia, most of these transplants are cadaveric transplants, not living-related transplants. So this is another chart, which graph which shows how the number of transplants have increased over years. From 1968 till 2008, you could see a dramatic increase in the number of transplants, and also the countries where transplant programs have been started year on year. And closer in Asia, if you look at what has happened in India with pediatric liver transplantation, the first transplant was done in 1998. The first cadaveric transplant was done in 2007 over here. And then you can see all the major milestones which has been listed. So from one center in Delhi, now you can see that there are 135 licensed centers in India, of which around 10 do pediatric transplants. And if you look at Tamil Nadu, the state in south of India, there are 30 centers in that single state in India, when 30 years back, there were only 20 centers all across the world. So transplantation, liver transplantation in adults and in children is there to stay, and the numbers are only going to go up. It is just where we are at the curve of that programs. So, and yes, it's happening all across the world, but does it mean it's successful? So if you look at the data about pediatric liver transplantation from 2011 to 2018, you could see that in 60 months, 5 years, the survival rate is around 94%. This includes chronic liver disease and metabolic. It includes all the causes of liver transplantation. And the graft survival is around 87%. If you look at the fact that some or most of these children would have died within, say, 1 or 2 years if they didn't have a transplant, this is excellent survival. And what about the projected outcomes a few decades back, and what about the outcomes in the coming decade? So if you look at the 20 and 30-year outcomes of pediatric liver transplants in the United States, they looked at 3 cohorts. So those who were transplanted between 1987 to 1996, 1997 to 2006, and from 2007 to 2017. So if you look at here, the survival has improved. You can see that the survival is going up. So the 30-year survival for the previous cohort was 58%. And in 1997, those who transplanted between 1997 and 2006, it is projected to be around 68. But for the group who were transplanted between 2007 and 2018, they're projecting an approximate survival of 80% in 30 years, which is excellent. So the survival is going to go up. The projected survival is going to go up. And what about with children who have received transplant and now have become adults? So there was a study which looked at children who received transplant between the age of around 1 year to 3 years, 84 children. And you can see the most common indication as with pediatric liver transplantation was biliary atresia. There was a variety of causes. This study is from the UK. And then when they looked at 20 years survival, this is actual survival and follow-up over 20 years. Around 97% survived, 65% had normal renal function, 77% had normal renal function, 91% had normal BMI, and there was more than 70% who had no mental health disorder and had good adherence. But if you look at it differently, 25% will have some sort of renal dysfunction within 20 years. And not all of them had the perfect outcome. So there were a lot many who were not in employment. There was incidence of mental health disorders, which was high, but not as high as compared to the general population, but it was still high. So when they looked at children who did not have any of these complications, there were only 26% who had that. So they named it as meaningful survival. So outcomes are good, but there is a lot more to be done about the quality of life. And what about transplantation for metabolic liver disease? Again, as compared to biliary atresia, the outcomes are excellent. So now coming to what are the indications for pediatric liver transplantation? So I would like to divide into 4 major groups: chronic liver disease, acute liver failure, which Chai has already touched upon, and transplantation for inborn errors of metabolism, and for liver tumors, including hepatoblastoma and hepatocellular carcinoma, fairly benign tumor. So I would like to concentrate on the chronic liver disease and the inborn errors of metabolism in this slide. So you can see that the liver disease, the chronic liver disease, could be due to a variety of factors, including cholestatic disease, metabolic liver disease, autoimmune, in some inborn errors of metabolism. Liver transplantation can serve as an enzyme replacement therapy, like for urea cycle disorders, when the liver is not diseased, but there is a defective enzyme, and an enzyme is an absence, where you can do a transplant and replace the enzyme essentially. So what are the common indications? So the registry data from US, which is published in 2019, what they've shown is that biliary atresia still remains the most common cause, approximately 40%. Metabolic liver disease is a very important cause, around 20%. Tumors and liver failures come around 10% each, and genetic and cholestatic disorders around 10%. So the biliary atresia remains the most common cause worldwide, but the other indications vary depending on the area or the part of the world from which the data is published. So looking at children with biliary atresia, as you all would know, they will miss the Kasai, so their only option for survival would be a transplant. Most of them will have a Kasai surgery, but unfortunately 1/3 will fail to clear jaundice, and they will need transplant soon, maybe within a year's time. 2/3 will clear jaundice, and 50% will have their own liver at 10 years of age, but around 50% will develop complications and then will need transplant. So looking at the indications for liver transplant in the children with biliary atresia, it could be nutritional problems where we are not able to maintain appropriate nutrition in spite of trying everything. Recurrent cholangitis, recurrent episodes of life-threatening cholangitis itself is an indication for transplantation. And complications related to portal hypertension when they have bleeding, or ascites and spontaneous bacterial peritonitis. Severe pruritus, life-limiting with extreme poor quality of life pruritus could be an indication. Pulmonary disorders, including hepatopulmonary syndrome, is another indication for transplantation. Rarely, they do develop liver malignancy. Now, looking at liver transplantation for metabolic diseases, they can be broadly divided into 3 groups. So those are metabolic diseases which cause liver damage. Typical example would be Wilson's disease, where they have cirrhosis, portal hypertension, and then will need transplant. Or monogenic diseases where there is a hepatic expression, but there is no liver damage. Example would be urea cycle disorder, where the enzyme is deficient, the deficiency is in the liver, but the manifestations including encephalopathy is in other organs, and liver transplantation will cure it. And then monogenic diseases with hepatic and extrahepatic expression, where for organic acidureas, where the enzyme is defective in the liver or absent in the liver and is also absent elsewhere in the body. And liver transplantation essentially will serve as a replacement for the enzymes. So, and the next indication would be acute liver failure. Chaya has touched upon this. The most common indication, as you could see, we still indeterminate. That means we still don't know for most of the children why it could be infectious, it could be metabolic disorders, which we don't know. And then this is data from the US. So paracetamol, viral incidents, and metabolic disorders, all we don't know. So what I want to stress upon over here is the clinical trajectory of a child with acute liver failure. So you can see that if this is graph is the course which it will take, transplantation, which is the green dot over here, might be needed at any point. So that is why, as mentioned previously, it is very important to refer the child or discuss with a transplant center as early as possible, because the child can deteriorate pretty rapidly and we need to be ready for the transplantation as soon as possible. The child might recover, but we need to keep all the options ready. So if the child is encephalopathic, in shock, on inotropes, the prognosis, the chance of getting through a transplant and the prognosis after transplant also decreases dramatically. And I would not touch on this. So, and then once, so I've stressed on the indications for transplant. What about the assessment? What are the salient points we need to look about? So the first and foremost is the assessment for a liver transplantation is always done by a multidisciplinary team. You can see the recommended members of it is an extensive team who has specialized experience in dealing with children and families for liver transplantation. And input from each and every member of the team is important for taking the family through the process and for the prognosis. So if I briefly touch upon the task of each and every member. So from a hepatologist point of view, it is the diagnosis, management of the liver disease before the transplant and while waiting for the transplant, and looking out for and managing the complications of transplant. And from the cardiopulmonary point of view, assessing the lung and the heart is really important. And children with liver disease, especially Alagille syndrome, tyrosinemia, and even other children, they are prone for renal dysfunction. So monitoring the renal dysfunction and planning the immunosuppressive regimens and the management of the liver disease itself from a renal point of view becomes important. Nutrition and immunization is really important. So I'm going to stress on that a bit more on the next slide. Dental assessment is really important. Children with liver disease, they are prone for dental problems. Also, post-transplant, if there is always a high risk of dental infections, which can lead to sepsis and problems after transplant. So it is important we correct it or treat it appropriately before the transplant. And from the anesthetic point of view, the anesthetic role is very important in taking the child through the process of transplantation. So it has been shown in studies that where there are specialist anesthetists, the survival after transplantation would be high. And of course, the most important person would be the surgeon, who has to assess the donor and the recipient and has to plan the surgery. So coming to important points from a pediatrician's perspective, nutrition. So nutrition is vital not only pre-transplant, but also during the transplant process and in the post-transplant period. So nutrition of a child with liver disease prior to transplant influences the survival after the transplantation. So appropriate nutrition increases the survival chance. And children who have appropriate nutrition, the risk and muscle mass, the risk of long-term stay in the ICU will also come down. So nutrition is an malnutrition independent predictor of outcomes, and it is very important that we address these deficiencies, the micro and macronutrient deficiencies. So there is a stepwise algorithm which has been recommended by the NASPGHAN from America. So regular diet initially, and then higher calories. It doesn't work. We need to go to higher calorie formulas. It doesn't work through oral nutrition. Then we have to try nasogastric or nasojejunal feeds. And if none of it works and the nutrition doesn't improve, that is an indication for parenteral nutrition, which we have tried for a few kids in our ward in the UK. And regular assessment, that is what you would see in this chart, every 2 to 4 weeks by the pediatrician or a dietetic team is really important so that we keep a track on these children. Because things, even a child might be stable on regular diet, but might need a nasogastric feed down the line. So it is important that we regularly assess these children. So children who are on a transplant waiting list in our program, they are assessed seen every month by the consultant hepatologist so that we don't miss any of these opportunities. And immunization. So the golden rule is that immunization prior to transplant is always better than immunization after transplant. So the children can have all the vaccinations as for the national vaccination policy, but they would need, in addition, hepatitis A, influenza, pneumococcal, varicella, and hepatitis B vaccine. So if there is a chance that a child might need transplant in the future, it is important that we give the child all the necessary vaccinations and be prepared. It may not be needed, the transplant may not be needed in 6 months, maybe not in 1 year, but if there is a risk, what I would advise is to make sure the child receives all the vaccinations soon before that. And those who are in urgent need or need a transplant within months, we have an accelerated schedule for transplantation wherein the vaccines could be given earlier than the recommended age. So it is published and is available for everyone. So hepatitis B, MMR, influenza, varicella, all these vaccines, there is an accelerated schedule which can be tried. And what about the recipient assessment? As you can see from this chart, based on the only thing that we need while assessing for a transplant is a blood group. We don't need an HLA matched donor, it's just a blood group matched donor. But what if you don't have a blood group matched donor? Doesn't matter. It has been shown time and again, especially from Southeast Asia and from Japan, that ABO incompatible transplants have got excellent outcomes in a long term. This is 15 to 20 years where they had 83, slightly less than non-incompatible transplants, but has got excellent outcomes if you don't have an appropriate ABO matched donor. And children less than 12 months who are having transplants, sometimes even less than 18 months, they don't need a matched donor. It is possible to do transplant without a matching because their immune system is not very well developed. And what about the type of graft? I'm sure the surgical talk would touch upon this. Most of the grafts would be left lateral segment or segment 2 and 3 because they're all usually small children. And while assessing for the transplantation, what we are actively looking for is there any contraindication for transplantation? So we may not be able to find out what exactly is the cause for the acute liver failure or the chronic liver disease. Doesn't matter. What we need to find out is there any active ongoing contraindication for the transplant. The absolute contraindication would be hepatocellular carcinoma, generalized extrahepatic malignancies, uncontrolled infection, wherein we are not able to get on top of the infection, multisystem mitochondrial disease. So I have to mention here that if the mitochondrial disease only involves the liver and doesn't involve the extrahepatic organs at present, then in the UK, we would consider them for transplantation. Of course, the final decision will be the MDT decision. And severe lung complication, which is not responding to medical therapy. But if this is not there at the point where we are assessing the child could be considered for transplantation. So when the data from the US, they have looked at children with acute liver failure, they found that sepsis, medically unsuitable, that would mean hypotension or unfit for transplantation, was the most common cause for not listing for a transplant. And assessing for the donor, I'm sure the surgical team, surgical talk would stress on this and further, so I'm not looking into this further. So I just want to stress on this because I used to work in India, is that there is always a set of checks and balances which is needed to make sure the right donor is there. So there is a need for documentation, and the donor needs to go to a set of processes before the child is taken. But this is, the child is then in India, but of course, if it's in Sri Lanka, that would be different. And so psychosocial aspects is really important because this is quite a stressful period for the family, the child, and also the donor. So it is important to identify the long-term risk, non-adherence, and all the risk, psychosocial risk. So it is important to have a good psychosocial assessment and help and support the family. The children and the families will go through feelings of guilt, inadequacy, stress, lack of control, uncertainty, anger, and it is really important we help them prior to transplant. So otherwise the complications and the problems will be much more. And so if I take you through the process of assessment, so the process, the steps would be a referral for the transplant, then the pre-transplant evaluation, which we have stressed upon, and then once we have discussed listing for a transplant, and then of course, this is mostly from the cadaveric point of view, but even for a living donor's transplantation, sometimes the donor might have to lose weight, there might have to be a bit of waiting period before the transplant. So from a pediatrician's perspective, it is important we optimize the child for this period of time so that when the child arrives for the transplant, the child is in the most optimal state. So it is important we nutritionally optimize the child, offer appropriate management of the portal hypertension, vaccinate the child so that the risk is less at the time of transplant. And the transplant and the post-operative period, what I would want to stress on this is a combined task with the transplant surgeon, the hepatologist, the intensivist. All of us have to work together to make sure that the child goes through this process smoothly. And once the child is discharged, it is important for the pediatrician's point of view for the long-term follow-up. It again lies with the transplant center to make sure that the appropriate follow-up and management of the problems, which I'm going to discuss now in the long-term follow-up, is done appropriately. And post-transplant, there could be a lot of complications from the neurological, respiratory, renal, hematology, metabolic or cardiovascular problems. But with an experienced transplant team, most of the children will get through these set of problems fairly easily. And what influences how the child recovers is how the child was nutritionally and overall state of well-being of the child prior to the transplant also. So these children have to remain on immunosuppressive medications for their entire life. And there will be complications after transplant for some of the children. It is expected. So what are the differences from the pediatric and adult point of view, especially from the immunosuppressive point of view? So the pharmacokinetics, where the absorption, bioavailability, difficulty in taking the drugs because they're young, they have to mix it with water or and give the drugs. And the fact that growth and development, which is not an issue in adults, it's there always there in pediatric recipients. And we need to tailor the immunosuppressive regimens for that. And also the fact that if the child is having a transplant at 1 year of age, he or she's got his entire life in front of him. And the risk of long-term complication, especially the kidney problems and all, might set in fairly 20 or 30 years down the line. So the family needs to be aware about that. And as I mentioned earlier, the basis of immunosuppressive regimen in a liver transplant is tacrolimus. Cyclosporin is only very rarely used. The number of immunosuppressive drugs varies according to the transplant center. Immunosuppressive regimen varies from transplant center to transplant center. There is no one single regimen which is best. It is what the transplant center or the transplant physicians and surgeons are used to and they're very experienced with. In our center, we use a 3-drug immunosuppressive regimen with tacrolimus, azathioprine, and rarely steroid. But there are some centers which use tacrolimus alone and a very small dose of steroids. So it varies from center to center. But what I would like to mention is that these drugs are all associated with complications, and in the long term also, from a pediatric point of view, and we need to be on the watch out for the complications. So what are the long-term risks of a pediatric liver transplant? So the risk of complication varies according to the time point from the transplant. So at 1 week from the transplant, it would be mostly not risk of non-function. This is mostly occurs in cadaveric transplants, infections, kidney injury, and broadly, if you could divide, you can look at it as a rejection, which is always there. I would say in the 5 years of post-transplant, there is a 50% chance of rejection, but with the new regimens we have, we will be able to manage most of the rejection episodes appropriately. There could be complications related to drug, either antibiotics, immunosuppression, biliary complications, vascular complications, including portal vein, hepatic artery, or hepatic vein complications. Biliary complications is always there, and the long-term risk of infections and malignancy is always there. So one of the most beautiful things which I've heard from one of my professors is that what he said is that we are replacing a set of unmanageable problems wherein the child had chronic liver disease, has ascites, and is likely to die within a few months or years, with another set of manageable problems. It's not like the life will be without problems, but the quality of life would be good. And these are problems which we would be able to manage in the long run. So I'm going to conclude my talk about talking about a young child who was transplanted in Chennai when I was working in Chennai. So this patient is from Sri Lanka, and I got his permission from his dad, who's a doctor. So he presented in 2018 with acute liver failure. It's quite bad, and we are not able to find out the etiology in spite of extensive investigations at the time. And his bilirubin levels started going up. He developed ascites, and so he needed an urgent liver transplantation, which he had. He recovered without any complications, and we have been in touch ever since, even after I moved to the UK. So this is him now. So this is he had his transplant around 3 years of age, and this is him at his 5th birthday. This is him, the most recent photo. See how much he has grown. And he's lovely, he's enjoying his life, he's doing whatever he needs to do at his age. And then I asked his dad yesterday, what do you think about his life after transplant? So I knew the answer, but he just messaged me. So he's just like other children. No one will tell he had such a mess until they notice his scar on the tummy. And they only worry about the infection. This is the parents. He's not worried about anything. He's just enjoying his life as he needs to be. So this is my last slide. Thank you so much for listening to my talk. Thank you.